might occur. Today's topic is routine health supervision in children with trisomy 18. The purpose of my talk is to highlight and summarize current recommendations for health maintenance in children with trisomy 18. This slide shows a concise outline of what I will discuss over the next 20 minutes or so. First, I will provide you with a background and a summary of the manifestations of trisomy 18 to ensure that all of us are on the same page as we proceed. This talk will, by design, be rather abbreviated and focused. Other talks can provide more detail on some of the individual findings, such as heart defects, but our goal today is to leave with a plan for health supervision and maintenance, ideally a plan for a family and their doctor or practitioner. Some case nurse practitioners, physician's assistants, and I would encourage you to feel free to share my recommendations with your practitioners and other family members. Thus, the goal today is not to talk about pregnancy or newborn management, but what happens after a child goes home from the hospital. What are the issues that this primary care practitioner and the families should be partnering together about? To set the stage, as most listening to this talk know, trisomy 18 represents the second most common autosomal trisomy, that is the non-sex chromosome trisomy syndrome, and the third most common chromosome disorder in humans, with Down syndrome being the first and the 22 deletion syndrome being the second. So trisomy 18 is the third most common chromosome syndrome. The prevalence in live-born babies, that is babies at birth, is around 1 to 5 to 1 to 8,000 in population studies, with a figure of about 1 in 6,000 live-born babies being truly the best estimate. Again, as most listening to the presentation today know, trisomy 18 is a recognizable pattern of both medically significant birth defects, minor physical variations that allow doctors to make the diagnosis, an increase in both newborn and infant mortality, and the occurrence of a rather significant psychomotor disability. Today we're not going to talk about those second two issues, that is the mortality issues, the figures, nor issues around psychomotor disability in any detail. This picture is of Sarah, the first patient with trisomy 18 that we know of. This is the picture from Dr. John Edwards' first paper published in April of 1970 in a British medical journal called Lancet. Notably, the first case report of a person with trisomy 18 was back-to-back with the first case report of an infant with trisomy 13. They both appeared in the same issue of that British medical publication in 1960. So I scanned this picture from Dr. Edwards' original paper. He shared with us at a St. Louis SOF meeting that this young lady's name was Sarah. And many of you are familiar with some of the physical features present in this photograph. So let me discuss the physical findings and manifestations of trisomy 18 in more detail, because this actually informs and actually drives the recommendations that we're going to make in routine health care. After I discuss the manifestations, I will spend the last half of the talk relating to you the principles of health supervision in all syndromes, not just trisomy 18, and then I'll close with some recommendations for care. So the pattern that Dr. Edwards originally noted, that has been confirmed in hundreds of case reports and series of individuals with trisomy 18, includes the following. Phenotype is a word for the physical manifestations of a condition. That word is used throughout all of medicine. The individuals, the children, are small for their gestational age. They have a pattern of facial characteristics that are not by any means abnormal. In fact, they're rather cute and petite, but they are similar among children. There's characteristic configuration of the fingers and hands that I'll show you in the next slide, and were present in Sarah's picture. And most of the children at birth have a short breastbone or a short sternum, which is used by the newborn doctors and pediatricians as a hallmark to consider the diagnosis. Lastly, and most importantly, persons with trisomy 18 are at risk for a relatively long list of medically significant congenital malformations, that is, birth defects, that, as I mentioned earlier, will actually drive the recommendations that we'll make for management and care. I'm not going to go through that list in great detail, but just summarize some of the highlights. In this picture, we see two famous individuals up in the right hand, or Carey and Rachel, the children, the daughters of the two mothers, Pam and Chris, who formed SOFT, and many of those listening to this presentation know that picture and know those families. The young lady in the bottom panel, I kindly acknowledge her family for allowing me to show this picture. This young lady is not only depicted here, but is also the picture that's in a textbook of medical genetics I helped with called Medical Genetics by Lynn Jordy. But you can see some of the physical characteristics that in today's presentation I won't go over in detail, but including the configuration and positioning of the fingers, especially the index finger on both sides. And you can see a rather cute and petite face, but also her resemblance to other children that I suspect many of you know. This slide shows in the top panel a chromosome study, a karyotype of a boy with trisomy 18, who next to the blue cartoon, the blue picture, has the 3 18s. On the lower panel, you can see a picture of a newborn. You can see the vernix on the fingernails, showing the rather characteristic contour and configuration of the hands due to a change in the way that tendons are placed. Again, we won't go through that in detail. I'm just making sure we're all on the same page. This slide lists some of the important and more frequent complications that occur as part of the pattern that we call trisomy 18 or Edwards syndrome. At the top are the congenital heart defects, which occur in 9 out of 10 infants and children with trisomy 18. The second listed finding refers to joint contractures at birth, including very often club feet. The term arthrogryposis refers to those fixed or curved joints, which occurs in about 1/5 of children with trisomy 18. Spina bifida occurs in about 1 in 20 or 5% of infants, and eye abnormalities occur in about 10%. Defects or changes in the forearm bone called the radius also occur in about 5 to 10% of children and present some orthopedic challenges. Then there are a number of gastrointestinal birth defects. The TEF refers to tracheoesophageal fistula, a connection between the trachea and the esophagus, and omphalocele, which is the occurrence of the bowel through the umbilical cord, both occurring in about 1 in 20 or about 5% of children. Birth defects of the kidney or kidney malformations actually occur in 30 to 50% of children with trisomy 18, but fortunately they rarely cause any medical problems. Occasionally they do, but rarely. If a child does have a kidney malformation, it could predispose to urinary tract infections, which is something we do need to look out for. But in addition to the birth defects, there are a number of other conditions or manifestations that are highly frequent in infants and older children with trisomy 18 that present most of the problems that are well known and famous to all of us. The occurrence of central apnea, where the brain doesn't give a clear message to breathe. Other respiratory problems, both of the upper respiratory tract, the trachea, voice box, the tubes that lead to the lungs themselves. The occurrence of feeding difficulties, often requiring special intervention, like feeding tubes or a gastrostomy. The relatively high occurrence of reflux, where the milk products or other food actually refluxes up from the stomach into the esophagus and sometimes into the lung, playing a role in aspiration and feeding and breathing problems. And last on this list, but certainly not least, seizures, which occur in about 1 in 5 children with trisomy 18. Most of the time, the seizures occur after the newborn period, usually in the first 2 years of life, if they're going to occur. As most listeners know, it's these findings at the top, the central apnea, the respiratory problems of even the lung and of the upper respiratory tract, and the feeding difficulties that are very much tied in to the increased mortality and the illnesses that we see in babies with trisomy 18. And in fact, those problems that I just summarized really account for this increased neonatal mortality and infant mortality that is familiar to everyone in the audience. Again, something I can talk about in more detail with more numbers in a future talk. But in fact, it is this complex, this web, if you will, of this central apnea, the ability to not necessarily generate negative pressure, hypoventilation, the aspiration, sometimes not related to reflux, the upper airway obstruction, and the high frequency of heart defects that all seem to work together and really are the major challenges in infants with trisomy 18, and that ones that should actually play a role in our talking about routine care. So that closes the first 2 portions of my talk, and my friend here from Sweden and her older sister up over her right shoulder is well known to many soft families, and her family from Sweden was quite pleased when they knew that I still showed her pictures in my presentations. She, in this picture, is in her mid-20s. So in the remainder of the talk, I'm going to present a very concise and brief overview of general principles of health supervision in all syndromes, Down syndrome, trisomy 18, and so on. And then I'm going to close with the recommendations for care. So this idea of developing guidelines for health supervision, maintenance, and guidance really is a model that has emerged in pediatrics in the care of children, and more recently in genetics, only over the last 30 years or so. It's actually a quite brilliant idea. And in this slide here, I kind of go through some of the background aspects to the model. The AAP stands for the American Academy of Pediatrics, which has a program called Bright Futures, where they lay out the principles of supervision and guidance for all children. And this includes everything from immunizations to prevention of accidents and screening tests. They have laid this out for children in America, which are widely used throughout the world. In the 1980s, at the genetics meetings of the American Society of Human Genetics, American Society of Human Genetics, ASHG, I had the privilege to chair some sessions where we tried to develop principles to apply this model, this approach, to children with syndromes. And of course, we realized very quickly that in order to be able to apply this model of screening and guidance and care, we had to understand the natural history, that is, the individual components of a condition over time. And from there, from the 1980s, there was this idea that we would develop, geneticists and pediatricians and other medical people would develop these guidelines for children with all conditions. And I have, with some of my colleagues, have done them for both trisomy 18 and 13, and we'll talk about the trisomy 18 in a moment. From this, from the Bright Futures and from these meetings and from the study of natural history, a number of books emerged in the 1990s. Dr. Golder Wilson in Dallas, Texas, and Dr. Carl Cooley, who's a pediatrician and parent of a child with Down syndrome, published 2 editions of a book called Preventative Management. And they do include a checklist, and I've included it in this talk, for trisomy 18 and, in fact, for trisomy 13. Their books, however, are not available online, so they're not easy for you to get a hold of. And they're not easy for anyone to get a hold of unless they purchase the book, even on Amazon. Dr. Cassidy and Allenson wrote a book called Management of Genetic Syndromes. It's now in its 3rd edition. My final slide will give you that reference, and I have authored the chapter on management for genetic syndromes for both trisomy 18 and 13 in that book. And I'm going to summarize that again as we finish up the talk in the last few moments of the presentation. So this model, this idea, this framework of health supervision and guidance involves 6 principles that I've also summarized in other articles in the medical literature, one of which I will again cite at the very end of the talk. They have to do with making sure we know the absolute correct diagnosis, understanding the natural history or evolution of a condition, applying a screening approach like we do in newborn screening, using medical evidence to decide what tests we're going to pick, and the same applies to therapies. And then, of course, have provided both by specialists and by primary care doctors and practitioners ongoing psychological support, and, of course, for the geneticist, genetic counseling. Now, in the talk today, accurate diagnosis should not be an issue, but you can see already why it makes a difference. If a child has trisomy 18 mosaicism, or a child has partial trisomy 18 with only half of the long arm of the 18, that would make a difference in how we talk about these guidelines. This concept of natural history, a term that's used by medical people in this setting, as I've already stressed, is very important in this context. One of my mentors, Dr. Judith Hall, formerly chairman of pediatrics at University of British Columbia in Vancouver, has devoted many articles in the medical literature to outlining principles of natural history. But the idea is that all the conditions that we can discuss, trisomy 18, trisomy 13, Down syndrome, Turner syndrome, and so on, all have the development of specific signs, symptoms, and manifestations over time. Some of the signs and symptoms of trisomy 18 occur at a later time rather than at an earlier time. For example, seizures in trisomy 18. So it's important for us to actually have fairly accurate, unbiased information about the natural history of trisomy 18 before we embark upon our recommendations for routine care. But as you will see, if you were to go into the studies and try to collect every paper you could on infants and children with trisomy 18 or whatever syndrome you would pick, you would find that there's a significant bias in these studies because they're usually written by people in medical centers, and they're usually written by people who have more problems than other people. So there's a bias toward reporting the more serious or severe end of the spectrum, if you will. In addition, medical people, scientific people, will tend to write papers about conditions that are more interesting. So there is a bias toward publishing the more interesting or the rare findings rather than the medium or the universe of a condition at hand. And most of these studies are really cross-sectional. They're not longitudinal over time. So the point is there are problems with our studies of natural history. That aside, and that recognized, there are still people who have tried to approach the study of natural history of any condition by trying to lay out what they can. And one way to approach this is simply to look, like I've already done, at the frequency of specific manifestations, whether it be a heart defect or spina bifida, or for that matter, apnea. For some conditions, there's even been attempts to develop scoring systems of severity. And that's actually been done in a number of genetic syndromes that are common to geneticists, but not so much in trisomy 18 or even in trisomy 13. But from this, the American Academy of Pediatrics, again the AAP is American Academy of Pediatrics, has actually put together consensus groups of various experts who sat down and over the course of a year developed guidelines for a number of conditions. So you'll see at the top of this list, this has been done for Down syndrome. They were revised last year. It's been done for neurofibromatosis, and so on. At the bottom of the list, the most recent guidelines were done for the 22q11 deletion syndrome, also known as DiGeorge syndrome. This has not been done for trisomy 18, and so everything that you're going to see me present in the next few slides as I summarize the talk from here on in comes from my recommendations taken from my assessment of the literature with the help of many, with the help of colleagues and the help, in the case of our paper in Orphanet Journal of Rare Diseases, with the pediatric resident working with me, Anna Chareda. But everything you're going to hear me discuss from here on in is kind of my assessment as in thinking about what natural history and what we know about trisomy 18 as I would make for recommendations for care. So the remaining part of the talk, the remaining minutes of the talk will actually be my list of what we would suggest for primary care doctors and practitioners to have as really kind of a checklist approach so that nothing's missed, if you will, in routine care. So again, in order to develop these suggestions, we have to go back to our list, and I've now kind of framed the list in a different way for complications that occur in older infants and children. So of course the heart defects are at the top of the list, and as you'll see in the almost last slide, of course we're going to recommend cardiac evaluation, including echocardiogram. I'm going to spend a few minutes on the risk for Wilms tumor, which is a kidney tumor, because I do get a lot of emails and calls from throughout the world, but mainly from doctors, but also from parents about, is it necessary for us to be screening for this tumor? So I'm just going to spend, in a moment, I'm going to spend a few slides on this. But to go back to the list, scoliosis is a common spine curvature, a common complication of older children and, of course, into adolescence with trisomy 18, and should be followed closely because it can be a disability for the older child and adolescent. Problems with the light, photophobia, is a well-known problem that we really discovered at SOFT meetings early on in the 1980s, how consistent this was in children with trisomy 18. And problems with vision are common in older infants and children. Hence, we'll recommend ophthalmology consultations, eye visits. Hearing loss occurs commonly in older infants and children. Probably something unique about the hearing loss of trisomy 18, but I won't be able to talk about that in detail today. And then, of course, the developmental disability warrants that we're going to recommend referral to rehabilitation clinics and early intervention. So let me go back and say a few words about Wilms tumor, because at the end of the series of slides, we do make the recommendation to have a baseline kidney ultrasound, kidney sonogram, abdominal sonogram actually, and we recommend that to occur during childhood in older infants and children with trisomy 18. So why do I make this recommendation? Well, it was learned in the 1980s that there had been a few case reports of children with trisomy 18. One was of a 1-year-old girl. The other was an older 5-year-old girl who developed this kidney tumor. And when the papers were reported, they said, well, maybe this is a coincidence because, you know, two rare things could happen and maybe it's a coincidence. But then in SOFT meetings in the 1980s and 90s, we started learning about children who were members of SOFT who developed this kidney tumor at various ages, which I'll show you in a minute. As this started to become more evident, I had doctors write to me around the world, England, Sweden, other parts of the world, US and Canada, about children they were following who had Wilms tumor. So by the early 2000s, I was aware of about 11 individuals who had a Wilms tumor and trisomy 18. And these were summarized in a paper by Dr. Libby Anderson in the American Journal of Medical Genetics in 2003. And they're also summarized in the references I'm going to give you at the end. Oops. Sorry, something just showed up on my screen, but it went away. So if you look at the children, the average age is 5, which is older than the average child with this kidney tumor, which is usually about 1 or 2. The range is also longer. 2 of the children I knew about were detected by this screening modality, and 3 of the children did survive the Wilms tumor. So the question becomes, what really is the risk? And so I have estimated that the risk of a child over the age of 1 into early adolescence to have this kidney tumor, which can actually be malignant, a Wilms tumor, this risk is probably around 1 in 100 to 1 in 200. That is about a little 1% or a little bit less. And I came up with that number by simply taking the number of children over the age of a year, the number of children with trisomy 18, and the number of children that I knew about in America over a defined period who have developed a Wilms tumor. So I thought this risk of about 1 in 200 to 1 in 100 to 1 in 200 was high enough to recommend routine screening starting after 6 months of age, probably getting an ultrasound every 6 months. So here are the guidelines. I'll now show you 2 slides to close out here. Cardiac evaluation, certainly in the newborn period. Referral for early intervention, and later on for rehabilitation clinics if that is appropriate. Follow up on the growth curves that were developed by Bonnie Beatty in a paper in 1994 with collaboration with SOFT, and those growth curves are on the SOFT US trisomy.org and on the SOFT UK web pages. They're available for pediatricians. Airway issues, if commonly present, as I indicated, referral to ear, nose, and throat doctors and to lung or pulmonary doctors if appropriate. And I'm going to explain that asterisk in a moment. If there are feeding problems, which there commonly are, discussions of tubes, perhaps discussion of G-tubes, referral to a dysphagia clinic. Notice that I missed the spelling error. That's not dysplasia, it's dysphagia, D-S-Y-P-H-A-G-I-A. Sorry for that. Not just my spelling, it's my eyesight. Either way, I asterisked the last two. I did that because in the U.S. and Canada, and I don't know about Australia, but in the U.S. and Canada, over the last 4 and 5 years, there have been the development of complex care clinics in many children's hospitals in North America. We call ours Complex Kid Clinic. It's led by Dr. Nancy Murphy here at Primary Children's Hospital. And she and her colleagues work together with ENT doctors, ear, nose, and throat, pulmonary doctors, feeding specialists, gastrointestinal doctors, and it's really become quite an excellent model. And 2 of our older kids with trisomy 18 who have a lot of these complex care issues are followed in that clinic. I'm not aware if such a clinic exists in Sydney or Melbourne in Australia. I know that they have the children's hospitals that are capable of doing it, but I don't know if that model exists. But I'd like to see that happen in the future. So the second list of recommendations, of course, for hearing would be audiology, that is hearing screening both in the newborn period and then regularly through early childhood. Ophthalmology, referral to an ophthalmologist. As I mentioned, the kidney ultrasound in trisomy 18, baseline at 6 months, then every 6 months into adolescence. Follow-up for scoliosis, including perhaps referral, if appropriate, to an orthopedic surgeon. And then lastly, I put this down, I put palliative care team with question mark, because I've learned in recent years that there are many palliative care teams that exist, including the one we have here at Primary Children's called Rainbow Kids, that are not an end-of-life care team. They are not a hospice team. They're really a support service. But sometimes palliative care teams have gotten the sense that referring them means we're referring to hospice. So it's important to be aware that palliative care teams and what they comprise and what they do in different parts of the world are actually different. I wouldn't hesitate to refer any child I knew with complex issues to our palliative care team because they are meant to actually be a support team, not an end-of-life care team. But I think sometimes palliative care teams have gotten a different message out there. Anyone that heard the talk in South Dakota by Dr. Fenton knows exactly what I mean by a kind of a different approach to palliative care other than end of life. So that's my last of the text slides. This is my last slide, just emphasizing the papers that exist in the medical literature that have covered everything that I've spoken about today. The last 2 references are the routine health supervision table that we published in Soft Times in the August, September, October issue of 2011. Dr. Carey and I put that together. But lastly, the last paper there in the Orphanet Journal of Rare Diseases is online, free access. Anyone by Googling Orphanet Journal of Rare Disease, you will find their articles. You can find that article. And I'm proud to say that it still has a little red mark that says highly accessed. So not every paper has that, but that is completely accessible for anyone here to also let their own primary care doctor know about its presence. So I'm going to stop at that point. I'll leave these references up if someone wants to write them down. And I think at this point, Carey probably will start, maybe she already has, fielding messages that I would be happy to answer any questions. Is that Carey, do you want to take over at this point?
Absolutely, I appreciate that, and really very much appreciate the information, Dr. Carey. When you got into the recommendations, you know, Chrissy is almost 13, and just to hear really how things have evolved and really how apparent it is that things are evolving even over the last 13 years, it's just exciting to me as a parent. And yes, we do have some questions, and I just want to put a notice out there. First, I'm going to turn off the noise that happens if somebody either joins us or leaves. I just want to do that so it's not being recorded. I believe that is now disabled. Oh wait, disabled. Okay, now it is disabled. Okay, just wanted to make sure that was disabled. Also, it may sound, I'm going to mute my microphone while Dr. Carey is answering questions because it may sound like it's feeding time at the zoo. The bus is about to get here. Our dog goes wild when Chrissy gets home. So if, Dr. Carey, you finish answering this question and I'm not here, I'm getting Chrissy, please wait. I will be here in 2 seconds. So the first question, Dr. Carey, that all being said, and this is from Susan in South Carolina. How does the short sternum affect health? Rebecca's sternum looks short, but no one's ever really listed it as an official marker. And I believe you can also see these over in the corner, Dr. Carey, but if you're hearing it is enough, that's great.
I can see them. I can see Susan's, I don't know what order they're in, but to answer Susan's question, now I can see, Susan, your question right here. Hello, Susan. The short sternum does not affect health in any way to my knowledge. It is simply one of those clues or signs that the newborn doctors and pediatricians can use when they're thinking about the occurrence of trisomy 18 in a newborn infant. My rule that I teach the residents is that if you actually use your fingers and mark off the top of the breastbone to the bottom, and you look at that in the chest and abdomen of a baby, the sternum, that is the breastbone, by just estimating it, accounts for about 1/3 of that truncal measurement. But in a baby with trisomy 18, it's usually about 1/4. To my knowledge, it doesn't have any relationship to the development of scoliosis or anything else after that. It is simply just a clue. So I see the next question also from Susan. Maybe I'll go ahead and answer that. So again, good question. So the question is, are the rocker bottom feet included in the club feet statistic? Probably yes, although I can't say that anyone actually, would have separated the different forms of a congenital contracture of the foot, of a fixed foot. That is the metatarsus varus or the classical talipes equinovarus, but sometimes a rocker bottom foot is part of a more complicated foot deformity called a vertical talus, which does often require casting and surgery and does occasionally occur in trisomy 18. So I think that the full-blown rocker bottom foot with a vertical talus probably is in the club foot data. That's roughly about 30%. We could scrutinize those numbers. But a pure rocker bottom foot, that is the prominent heel at the back with the rocker bottom configuration without any positioning change, probably are not in those data.
All right. Well, thank you. All right. The next question, Dr. Carey, is Tara from Nebraska. Are trisomy children at increased risk for food allergies because of the GI tract issues?
I am not aware. I'm not aware that children with trisomy 18 are at increased risk, but I am reasonably sure that it has never been studied. So we know that there are some food allergies that have some genetic bases, and thus you can imagine that the extra 18 has a predisposition, but that would be purely theoretical. I'm not aware of any food allergies. It's one of those issues that, that Deb runs in her registry, in her TRICE registry, that one could talk about possibly studying, but I'm not aware of it ever having been looked at.
Excellent. Well, and actually, She'll be doing one of our talks here in a couple of weeks. We can ask the same question of her. And in fact, ahead of time, perhaps, and in fact, she's on the line. Debbie, that gives you some information for the talk here in a couple of weeks. The next question, Dr. Carey, from Susan in South Carolina. When referring to trisomy 18, is there a distinction in accurate diagnosis between partial, full, and mosaic trisomy? Are there papers supporting studies differentiating them? And is routine care differentiated between types of trisomy 18?
Again, Susan, fabulous question. So if we just take one body of literature and we look at the population studies, and there have been about 10, and if there's a swell of interest in my reviewing those data, like I've done at some soft meetings over the years, happy to do that if there seems to be interest in actually going through those. In those population studies from the UK, Australia, Denmark, and Utah, and so on, there's several from the UK, one from Australia, they usually make a distinction between partial trisomy 18 and trisomy 18 mosaicism as not being included in the mortality statistics. And usually when they do it, when they come up with the prevalence figure, the frequency figure, they usually have taken out trisomy 18 and partial trisomy 18. But on the other hand, it's very common for people to kind of lump it together and not necessarily make the distinction. So it's really important to bring out your question to make that distinction, because in trisomy 18 mosaicism, we know there's varying degrees of so-called normal cells with trisomy 18 cells. We know that it can modify this list of physical manifestations. And while I would probably make the same recommendations in partial trisomy 18 and trisomy 18 mosaicism as I would for complete or full trisomy 18, probably I don't have any completely firm grounds on saying that, but I think in the era of being safe, I'd probably make the same recommendations. One last comment, which I know is very close to Debbie Bruns's heart, because we talk about this. I mean, how do we know that any child with trisomy 18 has full complete trisomy 18 versus mosaicism? Well, we only know because almost everyone gets a blood test where they count 20 cells in the blood test, and that's it. There's no further testing done unless someone decides that maybe there's something different about a child's pattern. So maybe they'll do another blood test, or they'll do a more deeper test, or they'll do a skin biopsy even for studying it to decide whether or not there's other tissues involved. So really what I'm trying to say is that while in any child, complete full trisomy 18 is based on a blood test that counts 20 cells, and that's probably 95% accurate in the way that they define that, we actually don't truly know with as complete certainty that any child doesn't have some degree of mosaicism. So that was probably more than you wanted me to address, but again, it's a good question to bring out those points.
You know, Dr. Carey, you've got to remember the group you're talking to. I just found what you just had to say fascinating. I think all of us do. I actually am going to kind of add a follow-up question here before we go to the next one, or a comment maybe, because I've always wondered that with Christina, where she is full, with the number of cells they test. You know, my thought on it's always been, though, you know, how many cells are going to, cells are we going to test to find the ones that aren't, but I truly believe that it didn't matter, because we're going to do the same thing for her regardless. And so it's just, that was very fascinating to hear what you had to say there. And so the next question is,
go ahead. Well, no, and you're right, Terry. There are children that I know with trisomy 18 who have had, and there's at least 6 in the medical literature, who are older than a certain age, 5 to 10, where multiple tissue samples were taken, and they did have complete and full trisomy 18. So we know that as well as we can tell, children with full trisomy 18 will be in our groups of older and surviving children. So it's not just because they must have mosaicism, which is often stated.
I like that. That's awesome and very exciting. So that being said, and another question, and it starts out with Barlow had indicated that the mortality rate for trisomy 18 was better in the 70s and 80s. This I find another fascinating question and could be a whole great discussion. If that's true, you know, do we really want an accurate diagnosis prenatally? Is it negatively affecting the numbers, do you believe? What are your thoughts on that?
So, I think I saw Barb mention this in one of our recent email trails. So if you look at the population studies that have been done, really the true population studies, they take a geographical area over a defined period of time and attempt to ascertain every child with trisomy 18. They really began with the paper in 1985, and they go on after that. Prior to that time, everyone was basing their numbers, including all of our textbooks, on a study by Weber that was published in 1968. And what Dr. Weber did was he astutely collected several hundred cases of trisomy 18 from chromosome labs and got as much information as he could about their outcome. So this was a cross-sectional study that is, in this period of time, collected from chromosome labs in different parts of North America. And what he did was then say, okay, now let's go back and say what happened after we collected the case as well as we can. The survival figures from his study are actually higher survival than all the population studies after 1985. So rather than 50 to 60% of children with trisomy 18 dying in the first week of life, and please realize that, and it's not a figure everyone has heard on the line before, but if that's what came from the population studies, Weber's study showed better survival in that first week of life, better survival at 3 months, better survival at 6 and a year than all the population studies, which were relatively consistent. Now, as I think Barb knows, I have suggested that the reason for that could be that maybe children who died in the first few days of life weren't diagnosed, because remember, this was 1968, Edwards' paper was 1960, there wasn't as much awareness of trisomy 18, so my idea was a lot of children who died in the first few days were left out of that analysis. And to support that, we looked at our Utah data, and we took only children who were living at a month, and we looked at their survival after a month, and it was identical pretty much to the other population studies. However, having said that, at the time in the 1960s, newborn nurseries didn't quite exist. There were some, but there certainly wasn't any of the present circular reasoning, which is we don't intervene in trisomy 18 because they don't survive. I think everybody kind of has a sense of what I'm trying to say. Thus, there wasn't any of that. After 1985, there certainly was a sense of, well, we don't really know the true outcome if there would be more intervention. We only know what these population studies show us. We know from the Japanese studies of both heart surgery and Dr. Kosho's work at Nagano Children that more intervention increases survival. So I hope I'm answering the question, which is I believe that the mortality rate was better in Weber's study because there were a lot of undiagnosed kids and it was cross-sectional and it wasn't a population study. But how to assess the outcome of the population studies has to be tempered with that we don't really know what would happen if the traditional non-interventionist view was not invoked. So I hope that was not too wordy and made some sense.
Again, you know, very, very good. These Q&A actually has been very helpful. I hope that on time-wise, you're doing okay, everybody's doing okay. If you start to feel, just to let you know, Dr. Carey, if we're starting to either reach the time you need to get going, we can always get back together and do some answers because we have a handful more. What I'm going to ask now is if anybody else has any questions, don't post them, send them to me, and we'll do that for any future questions, because I actually can foresee maybe a Q&A night coming, Dr. Carey, if you'd be open to it, because people seem to be really liking this. That being said, the next question, do you know if the statistics for Wilms tumor also include nephroblastomosis?
Also a great question. So it's nephroblastomatosis, Terry, but it's one of those things you have to like break into its syllables to be able to say. So they do not, they include children, those 11 cases I mentioned were children who definitely had full-blown known Wilms tumor, biopsy proven. But the question is a fabulous question. Nephroblastomatosis is a condition of the kidneys involving a collection of cells that are thought to be pre-malignant. The best way to think of it is nephroblastomatosis to Wilms tumor is like a polyp to colon cancer. We don't really know very little about whether if someone has nephroblastomatosis, we can worry and think that the risk of Wilms tumor is increased, but we don't know that for sure. But here's an historical point of note. Dr. Beckwith, who's a now retired pediatric pathologist in San Diego and Montana, found nephroblastomatosis in some children that he studied who had passed away with trisomy 18 in the 1980s, and he predicted before the cases that children with trisomy 18 could be at risk for nephroblastomatosis. When I met him years later, I actually told him that his prediction was in fact true. But go back to the question, those numbers don't include plain nephroblastomatosis. They only include kids who went on to actually have a biopsy-proven Wilms tumor. Another good question. That is another good question for potential study. It's always interested me that the Wilms tumor gurus have never latched on to trying to study trisomy 18 in more detail. That's always surprised me, but anyway.
Well,
I can see Susan's, sorry.
I was going to say, if we have our way, maybe those things will change. And so I guess you see, is it more likely to be in horseshoe kidneys, or is there no obvious distinction?
That's a good question, because we could say that we could go back, I know we could go back to some of the 11 children and just know whether they had a horseshoe kidney, because Susan probably knows from asking the question that from series of children who passed away, not from doing kidney ultrasounds, but from kids who passed away, horseshoe kidney occurs in as many as 50% of children with trisomy 18. It means that the two kidneys are fused at the bottom and form a horseshoe, just how it sounds. It's a good question because we know that one Wilms tumor gene that is called PAC6 also, when mutated, can cause horseshoe kidney. So there's a logic to wondering if there is an increased risk, but it's not, again, ever been studied. And I wouldn't be willing to say that a child with the horseshoe kidney has an increased risk without there being more studies to say that was the case. Of course, I'm going to be recommending the monitoring either way, but I don't know whether if someone has a horseshoe kidney, they're at the higher than 1 in 100 to 1 in 2%, or 1 in 200 risk.
Okay, all right. Well, good answer there. And Rachel from Australia asked, if my child is 2.5 and is still on oxygen, can I assume that he will need this for the rest of his life?
Also a good question. I don't, from even another caller who's on the phone, I won't mention her name, I know that there are children with trisomy 18 who have been on oxygen, who did get weaned off of oxygen with time for other reasons. Partly to answer Rachel's question, we'd want to know what the reason why he is on oxygen. So if it's pulmonary hypertension related to secondary lung or secondary heart there is a reasonable chance that you'll need an extended period of time to be on oxygen. But if it's related to problems that lung growth can help, or that if there's upper airway problems, like even tonsils, that when removed would relieve some of the obstruction, then I'm not sure that he's destined to have oxygen for the rest of his life. I think it would depend on teasing out all those different reasons I had on the 5th or 6th slide.
Excellent. Well, it just goes to show there's always room for hope, and that's what we just always have to count on. And as parents of trisomy kids, we know that's a daily part of our lives, is believing in them and expecting that they can, and being prepared that they might not get off the oxygen. So that's good. Dr. Carey, Susan also asked, this is a scoliosis question. Chrissy has scoliosis. I know a lot of our kids do. For those with infantile scoliosis, is it true that the casting methods do not work in those with genetic conditions? Do you know of any kids that were actually casted, not TLSO casted, but corrective series of serial casting to correct scoliosis?
So I see the other question that Susan has underneath about the data. So I personally don't know anyone who was braced or casted in the early years of life, and maybe that's a question out there. I think that Susan actually posted this question on the email at one point as well, and I didn't answer it. I don't know of anyone myself, but it's certainly something that we can poll with other parents. I think that the reason that the doctors are saying that in infantile scoliosis, and here I'm going to answer this in the context of other causes of infantile scoliosis, not trisomy 18. But as I work with our scoliosis expert here who does that, rib expansion surgery that we do here at Primary Children's Hospital, one of the centers that does that rib expansion surgery, and I see those kids, is that when someone's presenting in the first few years of life, they probably have a different class of scoliosis and a different reason for having it than someone that presents at 7, 8, 9, or someone that presents with another osseous condition, neurofibromatosis, at 7 or 8. They're probably a different species, if you will, of scoliosis, and in that group, the bracing and the casting that they do and the changing that they do, again, speaking out of turn here as a non-orthopedist, they don't find it working in skeletal dysplasias, in conditions that cause birth defects of the vertebral column, in certain neuromuscular conditions that cause infantile scoliosis. But I think it's back to the cause. And, if there's an earlier presentation of the positional scoliosis that occurs in trisomy 18 in a 2 to 3 year old, while we certainly don't want to decrease their quality of life, I don't know that it wouldn't work and might not prevent the progression of the curve that we're worried about. Having said that, I definitely would want to make sure that if someone was braced or casted in those ways, that we already had some sense that the benefit outweighed the risk, and that's not something that I can address either in knowing trisomy 18 or even knowing their technologies. In the last part of Susan's question, I don't think there's any evidence-based data on this. Certainly there isn't in scoliosis for trisomy 18.
All right. Well, I'm going to mention something that Tara from Nebraska wanted you to know, or wanted to just mention, and that's that the University of Nebraska Medical Center apparently is interested in looking at the correlation between trisomy 18 and Wilms tumor, going back to our last question. And so we've got 2 more questions, and then we'll be ready to wrap this up. And so,
Carey, really quick, if you don't mind, really quick, that was from our caller from Nebraska, and there are some doctors there in Nebraska that were interested in that. Is that what the message was?
The University of Nebraska Medical Center is interested in looking at the correlation between trisomy 18 and Wilms tumor. and that Tara, I'll get you the information so you know who it is that's sharing that, and get you guys connected on that so you'll know.
Very good. Okay.
Cool. I appreciate that. You know what? That's some of the stuff we can make happen with this. I am very excited about this platform. So then finally, we've got a question out of Canada. Holly Lynn wants to know, how does unrepaired TEF-EA contribute? And I'm outside my, I know you've told us, and anyway, I'm outside. I'm just going to repeat it. How does the unrepaired TEF-EA contribute to mortality of a trisomy 18 neonate who is receiving TPN nutrition?
So the unrepaired TEF-EA is the tracheoesophageal fistula and esophageal atresia. So that's the blockage of the esophagus at some place along the way, so it doesn't connect to the stomach. And then as part of that birth defect, the trachea, the windpipe, is connected, and that's the fistula. And so as I said on my fourth or fifth slide, and as Holly knew, tracheoesophageal fistula with the esophageal atresia occurs in about 5% of children with trisomy 18. And it always presents an interesting and important and overwhelming dilemma, because here this is always a question of the question that emerges, and it seems to be the type of setting that ethicists who get involved in discussing trisomy 18 will frequently bring up this scenario of whether one would do the surgery. And I've been in this situation numerous times over the last 30 years here in Utah, and have different stories for that account. So now, if a child who had unrepaired tracheoesophageal fistula and esophageal atresia is on total parenteral nutrition, it must mean that the doctors at the time decided that rather than connect the esophagus up with the stomach and repair the connection, or put in a G-tube so that someone could be fed, that they would in fact give nutrition through total parenteral nutrition IV-wise. So in my mind, the tracheoesophageal fistula would not, I think, contribute to mortality by itself. The issue would be, now I'm assuming that the child, the baby, is on the TPN for his or her nutrition, and having that not quite physiological administration of nutrition with all of its risks, for liver and infection of the line and all that would occur. So it wouldn't be so much the unrepaired TEF that would contribute to mortality. It would be the fact that the baby is on the TPN with its risks, as I said, line infection, liver, and the rest. And that it certainly, one could have a person in that particular pattern of TPN, and there are certainly many children that we follow at Primary Children's who are on total parenteral nutrition for all sorts of complicated issues for an extended period of time. I hope I'm answering Holly's question. So it's the risks of TPN in a baby that would convey the potential risks to me rather than the TEF itself. I would ask the question of, if the plan was, let's put someone on TPN and not have to take her to surgery or him to surgery for other reasons, the surgery choices being connected up, which may be very complicated, or put in a G-tube so that then we'd go around the block in the esophagus and we would give nutrition by G-tube. My pediatric surgeons that I work with here frequently say, if we're going to put a G-tube in, open surgery as opposed to closed surgery, like where they do it through the esophagus, which they couldn't do, if my surgeons say, if we're going to put a G-tube in, we might as well just close the fistula and the esophagus. That's what they usually say to us. On the other hand, if it's a big gap, that makes it a very complicated surgery. So I hope I've answered Holly's question. If I haven't answered Holly's question because of the uniqueness of this question, please, Holly Lynn, email me later with more details if you need to. My email is on the trisomy.org webpage, but it's my name, john.carey at hsc.utah.edu, because maybe I haven't answered that question adequately, because it's an important question.
Thank you so much, Dr. Carey. We all appreciate the time that you spent today. It's been just a fascinating time. I hope everyone agrees with that, and so appreciate your time and look